Hi, and welcome to the 2021 Academy of Surgery Fall Symposium. I'm Dr. Carlos Mourão, the host of this program. Today, I'd like to introduce our special guest, Dr. Angelo Caldarelli. Dr. Caldarelli is an Italian oral surgeon. He graduated from Lacrimal University, and he specialized in oral surgery in Rome, Sapienza University. He focuses on surgical treatment of impacted teeth using piezoelectric device and atrophic jaws rehabilitation using a reduced numbers of implants. He do many courses and lectures around the world about those topics. He worked in his clinic, Cardarelli, Clinica Cardarelli, in south of Italy with his brother and father, and also in Milan in San Raffaele Hospital as scientific advisor, and his adjunct professor at Vita Salute University in Milan. Thank you. I'm very glad to have you here, Angelo, and the floor is yours.
Hello, everyone. I'm very happy to be here today for another great webinar. And I would like to thank AB Dental for this amazing organization and amazing event as usual. Today, I will discuss about a new interesting technique in order to avoid the traditional lateral sinus lift approach using a new approach, a new minimal invasive approach with osseo-densification procedure. This is a very easy and safe procedure because using this approach, it's possible to reduce the invasivity for our patient during the sinus lift procedure, because using this osseo-densification technique, it's possible to perform the sinus procedure with the crystal approach. Also, as I will show later, in very extreme case. As we know, after tooth extraction, we will have an important bone resorption, especially in the buccal side. So after 3 years later, we will have about 40% of bone resorption with different speed and different direction. And especially in the maxilla, because as we know in the maxilla, the quality of the bone is different in comparison with the mandible. We have, especially in the posterior side of the maxilla, a very soft bone. And after tooth extraction, we will have an important bone reduction with the hyperpneumatization of the maxillary sinus, as you can see from this image. So in the maxilla, we have a very soft bone in terms of the quality. So after teeth extraction, we will have a hyperpneumatization of the sinus, as you can see from this Cbc reconstruction, with the centripetal resorption. So in the posterior side, after teeth extraction, we will have frequently many problems in terms of the implants rehabilitation, considering the bone resorption. For example, as you can see from this case, after the extraction of the upper second molar, only 3 years later, we will have an important bone resorption, vertical and horizontal bone resorption with a different time and different speed. So at this time, I need to increase this bone quantity with different procedure like GBL procedure, like crystal sinus lift, like lateral sinus lift, because as we know, the lateral sinus lift approach is a predictable therapy. As you can see from this case, this is my publication about the treatment of atrophic maxilla in the posterior side, because as you can see, we have an important bone reduction. This is the CBCT reconstruction. And in this case, according to the traditional technique with the lateral sinus lift approach, I performed this approach. I placed at the same time 2 implants, and I filled the residual cavity with autolog and heterolog bone. So this is a predictable therapy, and this is the healing 4 months later with a good osseointegration of both implants 4 months later. And this is the result at the end of this procedure, with also a good healing of the soft tissue. So this is a predictable therapy. Another case about the lateral sinus lift approach using the same protocol. The lateral approach, the implant placement, and the use of the autolog and heterolog bone in order to increase the bone around the implants. And during this procedure, as we know, is very important in the lateral sinus lift approach, as you can see from this image, to preserve the sinus membrane during this procedure is very important to preserve the sinus membrane during this procedure. But in some cases, we have an high risk to have a perforation of this membrane. So now we can change this approach, reducing the morbidity for our patient, reducing the invasivity with the same outcomes: less invasivity, reducing the biological and economical costs for our patient, obtaining the same result. Is very important, this concept. For example, have a look at this case. This is a young patient, and this is the intraoral view in the left side of the maxilla, and this is the CBCT reconstruction that shows this clinical situation. We have an important bone reduction. We have about 3.5 millimeter of height. And also we have in this patient a chronic sinusitis, as you can see from this image. This is the sinus membrane that you can see using the CBCT reconstruction. Obviously, in this approach, in the sinus lift procedure, is very important to have a CBCT reconstruction in order to understand better the anatomy, the shape of the sinus, the quality of the sinus membrane. So it's absolutely important to see and to have before the treatment the CBCT reconstruction in all cases. Don't forget this thing. So in this case, we have about 3.5 or 4 millimeter of height and 6 millimeter of, in terms of the thickness of bone. And how we can treat this patient with this approach, avoiding the lateral sinus lift procedure, using a very minimal invasive approach, using the osseodensification procedure. As usual, during the implant placement, it's very important to have a prosthetic guide in order to place the implant in the correct position, considering the angulation of this implant. So it's very important to have a prosthetic guide like this in order to place the implant in the correct position exactly like that. So I used, as usual, in this surgery, the full thickness flap with the palatal approach, because using this incision with a little bit palatal approach, it's possible with only one step, it's possible also to increase the keratinized tissue around this implant. And the keratinized tissue, as we know, is very important in order to prevent the mucositis and the perimplantitis in the years later after the osseointegration. So I can use, as I did in this case, the prosthetic guide in order to place, in order to prepare the implant site, exactly like this. And this is an amazing image because it's possible to see the sinus membrane. This is the intact sinus membrane. So using this procedure, it's possible to increase the bone, preserving the sinus membrane, as I will show better in the next image. This is the osteodensification procedure. Using a dedicated bars like this, it's possible to increase the bone in the sinus procedure exactly like this. So I will use, as I will show later, these bars in counterclockwise direction, no cutting direction, with high speed, with very important saline irrigation during the implant site procedure, like this. So this is the traditional approach. You see the bars in clockwise direction with the cutting direction. But in this procedure, we will use the new approach, the counterclockwise direction, no cutting direction, with the densifying mood. And with this approach, as you can see from this drawing, it's possible to increase the bone height in the sinus approach, preserving the sinus membrane. And this is an amazing procedure. So now I will show the short video about this surgery in order to understand better this procedure. And this is the situation after implant placement. In this case, I placed AB implant 5 of diameter and 8 millimeter of length. As you can see, this is the healing cap. I used the interrupted sutures, and this is the CBCT post-op. And it's possible to see the placement, the correct placement of this implant, increasing the bone height with the use of the heterolog bone. This is an amazing image after implant placement using the CBC procedure. So, with this procedure, I have the possibility to increase the bone height about 4 millimeters using only the crystal approach. And this is the resume about this surgical approach. 4 millimeters of residual bone height, as you can see, the implant site preparation, and the CBCT at the end of this procedure. So I increased about 4 millimeters of bone height using the osteodensification procedure without lateral sinus approach. And now, this is the video about this procedure. In order to understand better this approach, the situation at the beginning, as I said before, the CBCT reconstruction, the use of the prosthetic guide, the flaps design, and in this case, I used also the first piezo insert. At the first time, I used the piezo insert in order to preserve and to prepare the implant site, preserving the bone. And after that, I started with the osseo identification bands in counterclockwise direction with high speed, and the saline irrigation, as you can see, the second drill always in counterclockwise direction. The next drill again, according to the final dimension of the implant, always in counterclockwise direction, always. This is the image after implant site preparation. This is the sinus membrane. And now it's possible to use the heterolog bone, as you can see. So I filled the cavity with the heterolog bone, and I used the last drill in counterclockwise direction with the low speed without irrigation in order to push in the heterolog bone, increasing the bone height. Exactly like this. And then I can place the implant with high primary stability, as you can see. The X-ray post-op, the CBCT, and the suture at the end of the surgery. Very easy and safe approach. This is the healing 4 months later, using, as usual, the provisional, the temporary crown for 1 month. And this is the healing, because it's very important, the use of the temporary crown in order to manage the soft tissue exactly like this. And after that, I can deliver the final crown, as you can see from this image. Screw at the crown as usual. And this is the final aesthetic result with a good shape also of soft tissue, using the osseo-densification procedure, avoiding the lateral sinus lift. And have a look at this video in order to understand better the use of this drill. This is the comparison between the traditional drills and the use of the osseo-densification drills. And it's possible to understand better that using this drill, it's possible to preserve the bone during the implant site procedure. And as you can see from this video, using this drill in counterclockwise direction with high speed and saline irrigation, it's possible to expand also the bone in horizontal and in vertical direction, in both directions. So for example, I can use this bar only also for the bone expansion, because using this approach in counterclockwise direction, I have the possibility to increase the bone thickness and the bone height. And this is an amazing advantage in terms of the healing and in terms of the invasivity. for our patient. And it's very important to see this video using two different approach, the traditional approach with the traditional drills in clockwise direction, and the new approach using this denser bar in counterclockwise direction. Obviously, it's very important in this approach to follow always the protocol. This is the standard drill running in counterclockwise direction in a viscous material, as you can see, and it's possible to see what happened using this standard drill in counterclockwise direction. Have a look at this video. And now, using the denser bar in the same material in counterclockwise direction. This is an amazing image, an amazing result. Like this. So we have the possibility to expand and to preserve the bone. Exactly like this. So this is an amazing result for us. We have so the possibility to use these bars in the post-extractive implant placement exactly like this. After fifth molar, upper fifth molar extraction, we have this clinical situation. So in this case, using this approach, this is the X-ray pre-op, using the first drill in clockwise direction and the next drills in counterclockwise direction, exactly like this, with the non-cutting irrigation, with the important saline irrigation. This is the correct sequence. So at the beginning, it's possible in some cases it's possible to use the first drill in clockwise direction, but I need to use the next drills in counterclockwise direction with high speed, exactly like this. This is the correct sequence. As you can see from this short video, I used the drills in counterclockwise direction in order to prepare the implant site, and at the same time, I increased the bone height, preserving the sinus membrane. And after that, I place my AB implant, 4.2 millimeter of diameter and 11.5 of height, with an important primary stability. So using these drills in counterclockwise direction, exactly like this, we have the possibility to obtain this result, this amazing result, because this is the correct implant placement procedure, preserving the sinus membrane without manual osteotomy, using only the drills in counterclockwise direction. Exactly like this. This is the correct procedure, and this is the X-ray post-op after implant placement. Obviously, I filled the gap between the implant and the bone walls using the heterolog bone, because the heterolog bone in this case is very important. Is not involved in the osseointegration, but is very important in order to maintain the bone volume. So the use of the heterolog bone in this case is very important for the aesthetic reason in order to maintain the soft tissue volume. And I need absolutely to use the heterolog bone. The healing 4 months later, and the final result with the final crown, skewed crown as usual. This is the occlusal view. And now I will show another case, very challenging case, because as you can see from the CBCT reconstruction, we have only 3.06 millimeter of bone height. So an extreme case. Usually in this case, we perform the traditional lateral sinus lift approach, but now we can have another possibility, avoiding the sinus lateral approach using the same osteodensification procedure, as you can see from this video. This is the occlusal view, the full thickness flap, and in this case, I used directly the second drill without pilot drill, directly in counterclockwise direction, because this is a very extreme and challenging case. In fact, we have only 3 millimeter of residual bone height. So in this case, I need to use directly the second drill in counterclockwise direction without the use of the pilot drill. Exactly like this. Always high speed, counterclockwise direction, and saline irrigation, as usual, according to the protocol. The second drill in the same direction with the same speed. Okay, this is the implant site preparation. I filled the implant site with heterolog bone, the same protocol, and I used the last drill that I used for the implant site preparation in counterclockwise direction, but without saline irrigation, with low speed. Exactly like this. And I placed 4.2 millimeter of diameter implant and 8 millimeter of length. AB implant, as usual. The X-ray post-op, but it's very important to see the CBCT reconstruction. Sorry. Okay. Sorry again. It's possible to see the CBCT reconstruction, and this is an amazing result in terms of the bone increasement. This is the heterolog bone, and this is the intact sinus membrane using the crystal sinus approach, with easy and safe approach, with only one procedure, with the high primary stability. And now I will show the last interesting case. And in this case, I used this approach for both reasons, in order to increase the height and in order to increase the thickness of the bone, because this is the initial situation at the beginning. The CBCT reconstruction before, also in this case, we have about 3 or 4 millimeter of length, the full thickness flap procedure, the counterclockwise procedure using the same bands, the implant site preparation as usual, the heterolog bone procedure, and the implant placement. But in order to understand better this procedure, I will show this surgical video about this case. The full thickness flap procedure, 3.50 millimeter of high residual bone, so very extreme case. Full thickness flap as usual. The occlusal view, and also in this case, I used directly the second drill in counterclockwise direction without the pilot drill with high speed, as you can see. The second drill in the same direction, following always the parallelism between the teeth. Next drills again in the same direction. And this is the implant site preparation. The same protocol, bone grafting using the last drill in counterclockwise without irrigation with low speed direction, exactly like this. Low speed. And after that, I can place the implant, AB implant with high primary stability, 4.2 millimeter and 8 of length. Always high primary stability. The X-ray post-op. The CBC reconstruction too shows an incredible result in terms of the bone grafting procedure. The intact membrane, as you can see from this image, using only the crestal sinus lift with osso-densification approach. So I increased the bone height about 5 millimeters with only crestal approach. The sutures. And it's very, very important to see the result. This is the CBC reconstruction, as I said before, with an amazing result in terms of the bone grafting procedure, preserving the sinus membrane. The situation at the beginning and the situation after the osteointegration with a good healing in terms of the soft tissue shape. Because as you can see, we had this situation at the beginning, but now with only one procedure, using this approach, using a correct approach, it's possible also to increase the soft tissue in order to change the soft tissue shape. The situation before and the situation after, an amazing result. And this is the final result with the final crown skewed as usual. And now, the last video, in order to understand better this concept. And I think this is the future in terms of the implant site preparation, because using this approach, it's possible to reduce the surgical time and to reduce the invasivity. Using this counterclockwise direction, as you can see from this image, we have the possibility to densifying the bone with the autografting approach. So for example, we can use this procedure also in the mandible for the bone expansion, as you can see. So this is another application of this procedure. For example, in the mandible, I would like to suggest you the use of the pilot drill in a clockwise direction in order to cut the cortical bone. And after that, we can use the next drills in counterclockwise direction with the high speed and the cell irrigation exactly like this. This is the right protocol that you need to follow in order to obtain good results in terms of the bone and soft tissue stability. This is the densify procedure. And then we can place the implant. So I think actually, in my experience, according also to the literature, this procedure is a predictable therapy. And absolutely, we can use this procedure instead the sinus lateral approach procedure. And this is my publication with Dr. Arungard about this procedure, the crestal sinus lift using the ossification bands with some clinical case. So we can say that this procedure is a predictable technique. And I would like to suggest you the use of this procedure in your clinical practice. So thanks again for your kind attention. And if you have any question, please feel free.
What's going on, everybody? Hope you enjoyed that CE course that was just put together. Again, it's been a great weekend of learning. I know the AOS, it's a huge focus, right, for the AOS is to continue to educate dental professionals on things that matter. And so it's been a privilege to have all of these speakers with us this weekend. What we also wanted to do, as you have been seeing, is highlight some great companies, right? We know that running a dental practice is, part education. It's also learning about some of the great companies out there that are offering products and services. And I think most importantly, as you all know, as dental professionals, these companies are out there on a daily basis, becoming innovative, looking for ways to be able to help you grow your practice, run your practice in sometimes what are deemed crazy times. And so that's a great segue for my guest with us here from Dental Vault, Adrian Dre, who's going to talk about the topic of security and backup and all of these things that sometimes we want to kind of push out the back of our head, that, ransomware and all these things we've been hearing about when it comes to your dental practice and your files and that, but it's super important. And Adrian has a whole host of experience working with dental practices, particularly in the UK. He's done a lot of experience there. And so he joins us and he's going to talk about Dental Vault today. So Adrian, how you doing?
I'm good. Yeah, thank you ever so much for inviting me on. This is been looking forward to this. And I think what I really like, John, is you use the words crazy, back, and super important, because that's right. I'm going to be using them over the next few minutes.
Awesome.
You're absolutely right. The thing is that when you lose your access to your data, now it could be a whole host of reasons, right? Ransomware, which is on the increase. We can't ignore that. I hate scaremongering, but I have to admit it's on the increase and hitting dental offices in the UK and the US. Or it could be a server dies, or it could be some other tornado rips through your town, and whatever it is, you think, well, it's okay, we've got the data backups are there. But unfortunately, and this is where it gets crazy, is a lot of dental office owners, managers are finding out the hard way that those backups aren't there, or it wasn't backing up all the data, or it stopped working 6 months ago. And this is the correct word is crazy. because that is a crazy time to be in, because it's that sinking feeling of, but we need that data. That data is so important. So I think it's good to just sort of raise some awareness. And what I would say is that, yes, and this is the second word, back. It's called data backups, but it's usually in the back of our mind. You know, it's in the back office. We sorted that ages ago. It's in the back. But really, is your data in the bank? Because that's where it should be, like in a bank vault, which is the whole reason why Ian, the founder of Dental Vault, called it Dental Vault, because when we go around dental offices, what I've done in the UK and what Ian's doing in the US is the data backups are not in a bank vault-like situation. It's almost like when you've left your suitcase on the train platform. You know, anyone's going to pick that up. Yeah.
Yeah, it's interesting. As I'm hearing you talk about this, I'm thinking about even something as simple as our phones. I'm trying to kind of connect some analogies here. You know, many of us exchange our phones pretty frequently now, right? And so much of our data, our photos and things like that, our contacts live in the cloud. And so it takes me back to a point of being at the store and then getting a new phone or what have you. And then them asking me that question, is all of your data backed up? Because if it is, this transfer of, you know, everything that you've taken before is going to come on your new device. And you're right. It's always that feeling of, oh, like I knew I needed to do this, but I was busy and so on and so forth. And then you relate that to a dental practice, like you mentioned, who is busy on a daily basis. And in many cases, as we're seeing here, you know, particularly in the US, you know, the staff shortage of a lot of practices having to do more with less people and kind of battle through that. This becomes even more on the back of their mind, as you know, Adrian, to kind of take care of it. And it's not until something happens, unfortunately, which is where it gets very, very difficult. So, I mean, I just, speak to that and really kind of helping practices move through that muck of like, I know I need to do this, but how do I move forward and get it done for safety?
Well, I love that phone analogy, and I'm going to steal that if that's okay, because I think that's brilliant. Because if that's the convenience of it, isn't it? Today, you can quickly get a new phone, get your new iPhone or Android, wherever it might be, get that information. You've got all your contacts, got all your pictures, your kids, your family, holidays, that sort of stuff. And it's quick. It's quick and easy. If someone said to you, "Oh, actually, we told you that it was back. We've actually lost it," or they say, "Okay, we've got some of it," or they say, "We've got it, but it's going to take about 2 to 3 weeks until we can get it to you."
Right.
Now, obviously, there's a variety of frustration depending on what when they say, but yes, that is very much like it. So I'm going to steal that. So if I'm a dental office owner, dental manager now, and I'm thinking, right, okay, I'm listening into this, how the heck do I actually assess my backups? Okay, so there's some key areas, questions to ask. The first question is, how frequent are my backups? Now, there's some offices that don't back up at all, which is actually a HIPAA issue. But, if that's your case, you really need to listen in, because really what the frequency should be every day, I would say, is not good enough anymore. And the reason for that is because practices are moving at such a fast rate. You've got people booking appointments, cancelling appointments, and also probably the most important thing about having as much data available as possible is that we live in such a litigious society. Yeah. Dental negligence claims, malpractice claims. That particular record that you took the morning and you had an incident in the afternoon, that record could mean the difference on whether you win a case or not, right?
Right.
So to look at the frequency, I would say if you're backing up daily now and you're using those old tape drives, which we'll come to in a minute, that isn't really what that would be okay for a car shop or a vape shop or something like that, hardware store. For a dental practice, more frequently. So Dental Vault actually does every half an hour, which is when I found that out, my mind was blown. I didn't think that was possible for a dental office. That's like enterprise level, right? So frequency is important. The next thing is, are my backups being monitored? So practices have on-site backups, not great, and I'll explain why in a second. But even if you have cloud backups, don't just take it for granted that they're just automatically always working, because there's certain things that can happen, which means that backup hasn't been functioning correctly. So what mechanisms are in place so that you get alerted so that things can be made? Because it'd be the worst thing to think, oh, don't worry, I've got it backed up. It's in the cloud, but it stopped working 3 months ago. So how is it being monitored? And then the next thing about your backups, which we touched on earlier, is how quickly can I get back up and running? And this actually depends on the type of practice you have. So if you're a high functioning dental office, seeing lots of people every day, and if you're off, and this is the question, is how much will it cost you if you're offline for more than a couple of hours?
Right.
For a day, a couple of days, or weeks? Because for some dental offices, sort of quite small town, they could be off maybe a day or so. It's not great, but people understand. If you're in a city or whatever it might be, that could equate to tens of thousands of dollars. I mean, even if the backup is there in the first place, right? Even if it's complete, you want to make sure you can get back up and running straight away. And that could be rearranging patient appointments to having that radiograph available because you're halfway through an implant, whatever it might be. So it's that those are the three areas when you're reassessing it. How frequently are our backups? Are they being monitored? And how quickly can we get back up online?
Yeah, I love that. And so I think the other thing, as you know, Adrian, there's always, for anybody that's watching, you're sitting back and hopefully the goal is you're thinking about your practice. You're thinking about, okay, like of those three things, what am I doing? What can I be doing? And as you know, there's always that feeling of, okay, if I'm not doing any of those, if I'm only doing one of those, or, I need to get it done. So from your experience in working with dental practices, it feels like there was a time where going through this process was a lot more rigorous. If the further behind you were, maybe the more work it was going to take. And maybe that's still the case, but I'd love you to talk about today's technology, which is what's so exciting about all of this, which is, once you get over that initial overwhelm of I need to do better, right? I need to make sure I'm protected. It's a pretty smooth process, is it not? Like once you acknowledge those things and you utilize these technologies to provide yourself that peace of mind that things are going to be okay moving forward, and you get I think most importantly, you get the things in place that you need to, so that you can do what you want to do, which is take care of your patients.
Absolutely. And thank goodness I brought a prop because this is what a lot of dental offices are used to, right? They've got their old tape drives or they've got some external USB thing that's plugged in and they've got days of the week and they swap them over. I mean, that is talk about a mundane task to do that every day, right? So, I mean, if you took, maybe it only takes a few minutes, but you add that over the year, that's time that you could put towards marketing or other stuff to actually grow the practice, right?
Right.
So the technology that's available today, we hear a lot about cloud. You mentioned that earlier, John, iCloud and that kind of thing. That is the backup technology that's available. Now, albeit there are various levels of security when it comes to cloud, which is where you need to look at something like Amazon Web Servers, which got multiple billions of dollars worth of investment in to make sure they're as safe as possible. But you're looking at a cloud-based environment for your backups is super simple, but making sure as well that in that cloud environment, it's actually collecting all the critical data. This is something that actually catches a lot of dentists out when they get someone to do their backups. They just said, "Oh, just back up our patient records." But the thing is, your radiographs or your 3D images might be saved somewhere else. So it's only been backing up the clinical notes, which is okay, but you may need those other bits, right? How much the patients are actually owe you. Maybe they haven't paid for all their treatment. When you want to come back up, you want to know if Mrs. Jones still owes $15,000 for that implant or whatever it might be, right? So making sure that if you are using that cloud environment, that it's capturing everything. Sometimes dentists get caught out because they think, oh, we'll only need like 500 gigabytes or whatever it might be, and then it's going to be more expensive, which is what I kind of like about Dental Vault because it's unlimited. Mm-hmm. And when we're using more 3D images, they're big files, like they're massive, and that cloud's going to be pretty heavy, right?
Yes.
So it's good to look at the data thing. One of the big, and this is a nice little analogy I came up with the other day, and I'll ask you to rate it, John, if this is a good one to use.
Okay.
When you have a backup like this, which is just plugged straight into your server, okay? It's a little bit like jumping off the Titanic onto a lifeboat that's still attached, because that's how ransomware works. If it hits the main server, one of the computers, it spreads, okay? So your backup's really important. The effectiveness of the ransomware attack, of not paying the ransom, which could be $50,000 to get your data backup, it relies on them taking out the backup too, which is why I use that lifeboat analogy. You may think, oh, this is the thing that's going to get us out. But if it's still attached to the Titanic, you're still going down.
Right.
So that's how the cloud side of things can work.
Yeah, and I think I'm glad you brought up that point, because I think that stresses the importance of what you guys are doing at Dental Vault, and that is that this unknown world, the gigabytes and the unlimited data and the ransomware, it all is, for a lot of people, it's just scary stuff. Let's just call it like it is, right? And it's not scary because one doesn't take it doesn't make it important. It's just that it's the uncontrollableness, like you mentioned, Adrian, right? Like when you're, like you mentioned, backing up every half an hour in a dental practice because one file or one x-ray or whatever the case may be. I mean, that's just how important protecting data in a dental practice is. And so I think that's, the other great thing that you guys are doing is you're bringing that peace of mind to the practices so that they know that these things are backed up and they can do, they can do what they need to do, because again, it is one of the situations where it starts stacking on top of each other. And I don't know, maybe it was about a year ago, I had got a random email, even just in my email box, about ransomware and so on and so forth. And you just get that feeling in your, right? I mean, it's just hard to explain. It's just like this feeling like, it's, you can't control at that moment. Like, it's very scary. And so,
because you think, what's this going to mean for my business?
Right. Exactly.
Yeah.
Exactly. Yep.
Yeah.
So, all right. What I'd love to have you do is maybe talk a little bit about how you guys, how Dental Vault works. I think more importantly, I know you've got great programs. You can let everybody know kind of how they work. I think you have like an affiliate code. And like we've done with all of these interviews, everybody, the links that Adrian is speaking to are right below in the comments. So would love to have you click on those, go learn more about Dental Vault. And then Adrian, I know you want to speak to specifically the programs that you guys offer, things like that. And then of course the affiliate program, which that link will be below. So
thanks ever so much, John. Yeah, so we've got 3 packages, and what I strongly recommend, encourage people to do, is to click on that link to speak to one of our data integrity consultants to figure out what's going to be the best thing for you. And I've already touched on a little bit of that practices operate in a different way. Now, remember this, it's about your backing up that data, but also your disaster recovery, how you can get online as quick as possible. Now, we have 3 packages. All of them do the unlimited data. All of them are backing up every 30 minutes. Package 2 and 3 have this ability where you can get back online within the hour mark, to a degree of being able to access data, cancel those appointments, keep things running. So you're protecting your reputation with patients who are probably already a little bit frustrated when they come to a practice, right? Anyway, so you could at least you're knowing what's going on. The third package not only takes this cloud backup that we were talking about, but it also gives you a failover server which is connected. Now, you might be thinking, well, Adrian, you just used that lifeboat analogy. This is a separated piece of hardware. But what it means is that we can flip you over fairly quickly. So you're back up and running as you're used to, a lot quicker than just being able to access your data through a session, through a browser, on a laptop or that kind of thing. Yep. So the best thing to do is everyone's different, and we respect that. The thing is, we want people, any of our customers, to have the confidence of it's safe, it's frequent, and it is being monitored as well. Yeah. Those are the things. 24/7. So if your backup's being done by your local IT guy, got no offense to them, they love Dental Vault because there's a massive responsibility off their shoulders. Right. So if they can go on holiday and not have to worry about it, because Dental Vault, we've got teams of 20 around the clock are checking on this. You got an issue, you can give us a call. And that's a genuine peace of mind that we give you. Now, as I said before, click on that link book a call, one of our friendly, it's no obligation, even if it's a case to see what you've currently got, how it stacks up to the latest risk, you'll get a lot of value out of it. And what I say to people, John, so before I waffle on too much, if, in a very unlikely event, but if you had a data incident and your current system isn't up to date, but you can say to HIPAA, you know what, I watched this webinar or this fireside chat that we're having, and I thought I'm going to book a call in, and I was in the process of reassessing it. That can go a long way.
Yeah.
All right. Yep. Just obviously make the call as well, but that in itself, showing the seriousness of it, is important. And I encourage people to book that now, if they can, whilst fresh in their mind.
Yeah, I'm glad you brought that up as we wrap here. It's a lot of times when it comes to HIPAA and the like, it's effort, right? It's the fact that you made that effort to reach out, to start to go down the path to protect your data, the records of your patients, all of that, super important information. So, Adrian, this has been great. It's such a relevant topic. It's just, I know it's something that a lot of dental practices are thinking about. I'm so excited what you guys are doing at Dental Vault. Please, everybody, click on the link below, go check out what they're doing. If anything, like Adrian mentioned, just to give you peace of mind, so that you can move forward and do what you love best. So Adrian, thanks for coming on. I really appreciate your time.
Thank you.
And,
Privilege.
We look forward to seeing all the great work you guys continue to do.
Great. Thanks ever so much, John.
Hi, and welcome to the 2020 Academy of Oral Surgery Fall Symposium. I'm Dr. Carlos Moron, the host of this program. Today, I'd like to introduce our special guest, Dr. Simon Ho. Dr. Ho, he received his Bachelor of Science at University of Maryland, and he graduated with honors at the University of Maryland Dental School. Dr. Simon Ho is an oral maxillofacial surgeon, and then he has a special interest in dental implant surgery, all-on-X full mouth reconstruction concept, zygomatic implant, teeth in 1 day, and bone regeneration. Dr. Ho, he's one of the top dentists in Philadelphia. And I'd like to say thank you for your presence today, and the floor is yours.
Hello, everybody. My name is Dr. Simon O. I'm here to present to you today on extramaxillary implantology. It's an honor to be here, an honor to be a regent of the Academy of Oral Surgery. I serve as the Chief Clinical Officer of DSO called ProSmile. We're located out of New Jersey, Pennsylvania, and Maryland. So let's get going. So first and foremost, our agenda today is the treatment of natural maxillary atrophy. And then we're going to go through the treatment of what I call iatrogenic maxillary atrophy. And then we'll be talking about the transnasal implant. So what is natural maxillary atrophy? It is bone loss in the maxilla, either from long-term edentulosum, losing your teeth, long-term denture wearing. We also have sinus pneumatization and trauma. And typically the pattern of atrophy in the maxilla is up and back, or buccal bone resorption and inferior bone resorption. So what we typically end up with is a pseudo class 3 type of skeletal class relationship. So our first patient that we'll be going through is Mrs. VM. She is a 60-year-old female, or was a 60-year-old female, no significant past medical history. She's been in a denture since the age of 25, so quite a long time, 45 years of wearing a denture. She finally got sick of it, and so she sought out treatment. And so this case is actually very near and dear to me because it's the first quad zygoma I performed. And it's on a patient that I had already taken through surgery multiple times, regrettably. So the surgical history of this patient was initially we had wanted to avoid zygomatic implants, so we went for bilateral sinus grafting along with immediate placement. We used PRF with sticky bone And after 6 months, we re-entered the implants, and actually 5 out of the 6 failed. The bone in the sinus was just mineral. It was not vascular bone. And so at that point, we just had to bite the bullet and go for it. And so the actual plan was to place a few implants in the anterior, a single zygomatic implant on each side. But that didn't really work out. And so after about 2 years of bone grafting with BMP and all the swelling and everything like that, we finally put all that to rest in a single day with the Norris Medical zygomatic implants. And so you can see here, there's 2 on the patient's left side, 2 on the right. Multi-unit abutments that are 60 degrees. And here's closure. And so finally, after 45 years of denture wearing, 2 years of failed surgeries, we finally get this patient fixated teeth. And at her first post-op visit, she gave me a hug and said that this was heaven. And so that was just very gratifying. And here's the post-op scan. You can see the one implant that survived is on the patient's upper left. That survived a torque test of 35 Newton centimeters, so we decided to leave it. As you can see, I botched the healing abutment placement, as you can see on the x-ray there. And this is what the CT scan looks like. You can see we got up to the lateral incisor position with the anterior zygomatic implant, and we got second bicuspid on the posterior. The other side. Our next patient, Mr. LF, he's a 55-year-old male. Again, long-term denture wearer since the age of 30, so 25 years. He had a significant gag reflex, so he actually came into my office wearing a horseshoe denture and actually indented his ridge. And so it gave us a really difficult time trying to figure out prosthetically where to place the implants in the implant platforms. And as you can see, like we discussed before, this is a pseudo class 3. Every time I see a patient like this, I always ask them, when you were 14 years old, were your upper teeth in front of your lower teeth? And his answer was yes. And so you can see with 25 years of denture wearing, we have that classic buccal bone resorption and pseudo class 3. And here's a video. It's a bit distorted, but I think you should be able to get a sense of how little there was in the subnasal region. And so the treatment for Mr. LF included 4 zygomatic implants in the maxilla, 2 pterygoid implants in the posterior, and then 1 vomer that you can see right there with the red arrow. You can sort of appreciate how it's sort of midline. You can see it on this view. The vomer bone is a very small target above the nasal floor, which is included in the nasal septum. And you can sort of see how the apex of the implant here is very anterior to the incisive canal. Here's an inferior view. You can sort of get an appreciation for the converging zygomatic implants as well as the placement of the pterygoids. And here's a better view of that vomer. Again, it's meant to stay very anterior to the incisive canal, and it's above the nasal floor. So in terms of technique, we need to reflect the nasal floor, the mucosa up, and also reflect the mucosa off the vomer and septum. You identify hard bone, and then you actually visualize the burr with the nasal floor elevated. And so it crosses through alveolus, into the nasal fossa, and then into the vomer bone. You can even crisscross them. There is enough real estate for 2 implants into the vomer bone, so you can see on the right slide there's an apex there, and then there's an apex there, sort of going side by side. All right, so that was treatment of natural maxillary atrophy, and so in the next 10 years, with all these implants going in these days, we're going to have a wave of all-on-4 revisions coming very soon. It's going to become very invasive because, with all these implants going in, taking an implant out, most of the time we can back it out, reverse torque it, but a lot of times we actually have to trough it out. And so in doing so, we're getting rid of a lot of good real estate that we could use for that patient's revision. So this is a case where this patient had implants placed by a surgeon about a year prior. Actually, I did this case about a year ago, so about 2 years ago was the initial surgery. I read all the notes, and all the implants torqued out nicely, at least 35 Newton centimeters, but the patient was not immediately loaded. And so that decision to not immediately load, I have to believe, is what caused the resorption of all the buccal bone. And you can see on this slice of the x-ray that the entire apex of this implant is outside of the bone, and almost the entire thing is out. And you can see once we flapped it open that all the buccal bone was gone. You can see all the threads there. And so at the time of surgery, I have to assume that all this was actually inside of bone and that it resorbed, because I don't want to assume that the surgeon used poor technique. But as you can see here, this is not an ideal result, especially 1 year after having more denture. So out with the old, in with the new. So because of the amount of atrophy that has taken place because of the failing implants and the mechanism in which we remove these implants, we have to resort to more invasive treatment modalities. So in this case, our posterior tilted implant real estate was all Swiss cheese at this point, and so we had to go for zygomatic implants. So in this particular patient, we have 2 in the front into the piriform rim. You can see it engaging the nasal floor here. Okay, 2 zygoma implants and then 2 pterygoids in the back. And this was a rescue case, and so with all the resorption that took place, we were still able to get this patient teeth in a day. Here's a side view and panoramic. Here's another example of maxillary atrophy from iatrogenic causes. As you can see, 4 incisors with 4 implants. I don't think that this is ever going to be necessary for the sheer fact that this case could have been restored on 2, and had the principles of bone health had been respected, I think this would have turned out just fine. But the fact is that these implants are less than 3 millimeters apart, and that causes minimal space for bone to actually grow and thrive. And so we have this excessive bone loss in this front area, and in doing so, you can see the implants are actually touching. But again, because of the amount of bone loss that we had to resort to more invasive approaches. Luckily, we were still able to pull this case off for this patient, but it was a close one. And had we not had the use of zygomatic or pterygoid implants, this patient would have had to do some sort of delayed load, which would have caused, again, further buccal bone resorption. So the key for the future, the next 10 or 20 years or so, when all these revisions come in, is going to be utilizing these non-conventional or extramaxillary implants to reconstruct these patients. So here's the panoramic. As you can see, with the loss of all the bone in the front area here, we had to actually use the lateral piriform rim, which is actually the target for our distal maxillary implant. So because that's no longer there, we had to go to the zygoma. Here's an underbelly view. And here's another example of iatrogenic maxillary atrophy. This patient spent about 10 years in an academic institution trying to get this patient a full upper arch of teeth. And there were multiple rounds of grafting, multiple rounds of sinus grafting, multiple implants placed, few gingival grafts. And so What's the end result 10 years later? We have half of an FP1 bridge here, which is made out of Luxatemp, so not really temporary, and then nothing back here. And not to mention there's buccal bone loss on all these implants. And so here's our solution. Again, everything in the premaxilla is Swiss cheese at this point. And so we have to use non-conventional implants. So we have 2 midline, I wouldn't call those vomer implants, but those are 2 midline angled implants, 2 zygoma implants, and 2 pterygoid implants. We were able to achieve very high torque, very high composite torque value. And as you can see, the cylinders are on the multi-unit abutments. And so this case was immediately loaded. I think immediate load is going to be one of the most important aspects of what we do. For the reasons that I showed earlier. And here's an underbelly view. You can see the zygomas going nicely into the cheek there and the cheek here. And then we have our pterygoids into the pterygoid columns there. And then our midline implants there. Another example, 4 incisors, 4 implants. I don't think this is ever necessary. And it's because, implants need space. They need space apart from one another in order for bone to survive. And you can see, obviously, this is a little bit too close for this patient. And so we have all this bone loss here. Okay. And so the amount of bone we have in the subnasal region is only a few millimeters. This is at the time of surgery, so this was after the splinted implant to natural tooth bridge was removed. And you can see the destruction in this region. This is a very important region because this is where we usually place all of our implants, or we're gonna, like to shoot for one here and here, but there's nothing left. So our solution is 3 zygoma implants and 1 right into the vomer. Utilizing this alveolar bone. If I can avoid a quad zygoma, I will. And the reason why I like to avoid the quad zygoma is because if you only have zygomatic implants and nothing else that's sturdy, the prosthesis actually will move when the patient chews, because these implants are so long they actually do flex. All right, here's another patient, Mrs. RB. 50-year-old female. Her chief complaint was sore upper teeth. Her All-on-X was performed about 10 years prior. This patient has a history of refractory depression. She spends most of her time inside her apartment. She has very bad anxiety, even leaving her apartment. And she absolutely cannot tolerate a denture. So when I consulted with this patient, she made it crystal clear that she was not going to go home in a denture. And that's when I introduced the idea of zygomatic and pterygoid implants. And actually, this patient's surgical course was very interesting because I had to pivot mid-surgery. So this is how she presented. As you can see, there's lots of implant exposure. The angulation of these implants is very buccal, which generally tells me that the surgeon may have been a little bit on the naive side of this procedure. But regardless, we have a failing all-on-4, as you can see. And actually, when I took this patient's surgery, I was expecting to actually be able to access the prosthesis and back out all the implants by reverse torquing them. But little did I know that the access holes were completely filled with composite all the way down to the hex of the screws. You can also see that this patient has a combination of multi-unit abutments, custom abutments, and direct-to-fixture implants. So it's based off of this, from a forensic standpoint, it sort of tells me that implants were thrown in there, and the restorative aspect of things was not considered preoperatively. We had to, the doctor here had to work some gymnastics in the laboratory in order to get the case to work. But ultimately, in order to get this prosthesis out, we had to cut the prosthesis into segments and actually forceps these implants out one by one. It added an extra hour to my case, so that was not fun. But regardless, so after we removed the prosthesis and the implants, I placed 3 implants into the anterior premaxilla of this patient. None of the implants torqued well. I only got one that was at 35 newtons, and so with that said, I was planning to just place 1 zygomatic implant on each side, but I wanted to bolster the composite torque value, so I added 2. And so with an anterior implant in there, there are 3 anterior implants in here with lower torque, and 2 zygomatic implants on each side, we should be able to reach our composite torque value. Now, the issue that we ran into is that if you look closely, there's a green stick fracture here that extends all the way up into the piriform rim. And so this implant that I placed here was shot. I retested the torque, and it was not loadable. It was maybe 5 Newton centimeters. I checked another midline implant, again 5 Newton centimeters. These were torquing in at roughly 25 when I first inserted them, but I rechecked them after having seen the green stick fracture, and they were down to 5. This one here torqued at 25 still, and so with this configuration, you know, we have a poor amount of AP spread after the fact, after having rechecked these 3 anterior implants. And so what do we do at this point? I wasn't planning to go any further than this, but because of the positioning of the implants and the strength of the implants in these positions, we had to do something, because if we were to rely a full arch of implants on these particular 4 zygomatic implants, we'd have very poor AP spread. We'd have a cantilever on both the anterior and the posterior, which is not ideal. So our answer to this problem was to place pterygoids. And so having these 4 zygomatic implants and nothing in the premaxilla and 2 pterygoid implants on each side, we were able to pull the case off. We got good AP spread. We got high composite torque value. I mean, the zygotes always torque out at over 100 easily each time. So we have, let's call it conservative, 100 each. That's 400 plus pterygoids, which were 40 each. You know, that's 480 Newton centimeters composite torque. So more than enough. But regardless, the point I'm trying to make here is that without having the skill set or the knowledge of how to place these implants, this patient would have woken up in a full denture, and with her past medical history, that would have been a terrible thing for this patient. Now, as you can see here, this is the prosthesis. You can see how the spread of just these 4 zygotes in the anterior was absolutely not going to be sufficient. Canine to first premolar is just not enough. And so that's why we now add these pterygoids, and now we have an AP spread all the way to here. So we have 0 posterior cantilever and a very minimal anterior cantilever. And here's the result. And here is the panoramic x-ray. You can see I just left this one in here. You know, we had close to 500 newtons of composite torque and good AP spread. This patient is not somebody that you want to have to put through multiple procedures because of her mental condition, and so we just decided to bury that for later use if we need it. Another example, too many implants for a bridge. Also really poor keratinized gingiva. You can see there's pus everywhere. And just look at the amount of implants there are. There's just too many. And, you know, these look like press fit implants, which were, you know, largely used back in the 80s and 90s. And so I can't necessarily critique the treatment plan by this doctor just because that's how the thought process was back in the day. An implant for every tooth or an implant for every buccal root was the old way of thinking. But regardless, all these implants are now failing, and so what do we do at this point? You know, again, the premaxilla is going to be Swiss cheese. We have infection and everything of that matter. So this is the bridge removed. These are the implants that are removed, and you can see how the press fit implants have no threads. And so at this stage, we had to revert to a quad zygoma. We added pterygoids and a midline implant, okay, right there. I like to add, if I ever have to do a quad zygoma, I like to add rigid fixation either in the front or the back. And so the front would be either a vomer implant, a transnasal implant, which I'll show you later, or the pterygoids in the back. Those don't flex. You can also see here, this is a combination of not only extramaxillary zygomatic implants like these three, but there's also one intrasinus. And so this patient's zygomatic buttresses were not symmetric. And that's the reason why. The patient's right side was much more flat of an architecture than the left side. But ultimately, we got this patient rehabilitated, and she couldn't be happier. And again, it's teeth in a day, which is such a drastic change for most patients because they most of the time have been suffering for such a long time. And here's a view on CT scan, and you can see the lateral view. We have nice symmetry everywhere, and we have excellent angulation on all the implants, great AP spread all around. Here's a picture of the prosthesis. So you can see each zygo is placed nicely behind these incisors. We have excellent tooth position here, and then we have our pterygoids back here. And this is just such a stark difference from how things used to be when implants were placed solely intrasinusly. You know, this prosthesis, had this case been done 20 years ago, would have been something like this, with the access holes all the way over here, because the emergence was through the palate. And so these days we can have a zygoma case, a very complex quad zygoma case. We can have the prosthesis look like a traditional all-on-4, which is an amazing thing. Now, what's the problem with the quad zygoma? I think I mentioned it earlier, but the problem is that if the prosthesis is only on zygomatic implants and nothing else, the patient experiences significant flex when the patient chews, especially in the anterior, because those implants are generally longer than the posterior ones. And so the patient bites into an apple, they're going to feel some flexion of their prosthesis, and they complain it feels like a springboard. And so what can we do to solve this? Well, let's first look at how much this actually does bounce around. I'll show you this here. This implant is actually torqued in at over 200 Newton centimeters, but you can still flex it. It's not flexing at the bone level, it's the actual body of the implant is flexing. Okay. All right, so what's the solution? Is there a remote bone source for the anterior maxilla that's not so far away? We need an alternative to the anterior zygo and something that's more axially inclined, because you know, with the anterior zygomatic implant, it's coming at such a steep angle. It's usually at 60 degrees or even more. That causes, again, like you can imagine a diving board is flat. This is relatively flat. So what's the solution? Let's look back at the vertical maxillary buttresses of the face. And so there's three. There's the nasomaxillary buttress, the zygomaticomaxillary buttress, and the pterygomaxillary buttress. When we look at the slide that we all are familiar with from dental school oral surgery, we have these lines that are the strength lines of the face. And how did this evolve? It's generally speaking the points that are furthest out on your face that are the most prone to getting hit by trauma is generally the strongest, right? And so we've already utilized the zygoma buttress. We have utilized the pterygomaxillary buttress. Those are all D1 sources of bone, but we have not, or at least not as often, gone to this region, okay, the nasomaxillary buttress. And so what our orthognathic doctors are doing is placing these L plates for an orthognathic case or a Lefort 1 fracture reduction, is placing them into these buttress areas. And you can see here this L plate is being placed up here, which means that this is good bone. And so if you have an implant in the premaxilla, even if you have good height, you may not have good quality of bone. And so with my workflow, if I see an implant that's distally angulated in the piriform rim, that means I've already tried straight and midline. This is my third choice. And so straight midline did not torque. This one barely torqued, but on the patient's left side it did not. And so in attempts to trying to get a good implant in the front, we had to go to a remote bone source, and that's what this is. Okay. And so what's the technique of this? The technique is to reflect beyond the piriform rim, so above the nasal floor, but you also reflect nasal mucosa. So you reflect the nasal mucosa of the floor, but also the lateral aspects, because that's where your implant's going to pass through. You want to visualize the target, so you need to get your retractor up into this region so you can see it. And the end result is bicortical. So just like a zygomatic implant, we're going into bone and then back out of bone. And that's the same thing with this area here. It's also extremely important that you stay anterior. So one of the major vital structures that we want to avoid is the nasal lacrimal duct, which runs here and exits in the underneath the middle turbinate. And so here's a visualization of the technique. You can see that the amount of bone in the premaxilla is very minimal. And so this drill actually passes through. This is the nasal floor, and our target's up here. And all this mucosa is reflected. Okay. And this is what it looks like with the implant in. So you can see the implant actually does pass through the nasal fossa and engages up here. Now, you might think to yourself, like, how is this going to affect breathing? But fact is that breathing through the nose is not affected by obstructions or stenosis down at the piriform level. The internal nasal valve of the nose is actually what dictates airflow through the nose. There's something called a caudal test, where you lift your cheeks like this, and if the patient can breathe better, that usually means there's a problem with their internal nasal valve, which is actually in the superior portion of the nose. So this does not affect breathing unless there's a severe congenital problem where they have piriform aperture stenosis or something along those lines. And so here's what I was talking about. The nasal lacrimal duct is this structure. It's actually a very wide duct or canal, but you can see it's rather posterior. And so this is the apex of my implant here, and you can see that it's rather forward to this, and this is underneath. This is the exit, which is underneath the middle turbinate. And this is the diagram of the nasal lacrimal duct. So we have upper and lower punctae that converge down into this common duct area, and then ultimately it drains here. Okay. And so what does obstruction or violation of this duct look like? It usually causes the patient to have excessive tearing because they cannot clear their tears. This can also happen from inflammation post-surgery. So even though the implant is not in the duct, because there has been trauma relative in this area, it could cause the mucosa inside the duct to swell, and so swelling will cause a blockage of that tear duct, which is why for this type of implant I always place patients on steroids post-operatively, and they get a large dose of Decadron intraoperatively as well. All right, so here's a case of an extremely atrophic ridge. This patient was referred to me by a neurosurgeon, and essentially you can see how there's very minimal bone subnasally. So this is all we got, which looks like it could be enough, but you know, we have to get in there and see how the bone responds to our drills. And so it was deemed that it wasn't good enough. So when we drilled in there and tried a conventional implant, it did not torque. And so our options at this point are quadzygoma or something else. And so with this case, I wanted to eliminate any sort of anterior cantilever. I also didn't want this patient to have the springboard effect because, you know, obviously I want this patient to chew well. She's on the younger side of a patient typically getting zygomatic implants. And so I wanted to give her the best that I could. And so that's what this is. These are bilateral transnasal implants right into that good bone source for those L plates of a orthognathic case. We have a nice low zygomatic implant here, leaving plenty of freeway space if we need to. Say, for instance, this implant fails, we can then place an implant right there to rescue the case. We have two pterygoids in the back, well positioned. So at the lateral view, you can see we've achieved a nice amount of symmetry. We've also eliminated every cantilever, and this patient will not have a diving board for prosthesis. So overall, I think this is if we can come together and document more of these types of implants, and if we see that they work, we could really have something here. Now here's the underbelly view. So two well-placed pterygoids, two well-placed zygomas, and you can see how we were able to actually get central incisor positions with these transnasal implants. And so again, zero cantilever all around, having started from absolutely nothing. And you can see here again, this is the apex of patient's right implant, I believe. Nasolacrimal duct is here, clearly far away from it and not violating it. And here is the other side. Again, apex, duct, no violation. Now, what are the contraindications? At this point, chronic rhinitis I can see as being a contraindication, just like it would be with a nasal lift that some people do. Also, cocaine use is a hard contraindication. Like you saw before, the implant is only covered in the nasal fossa by mucosa. And so a lot of times we'll put collagen membranes in there or helitape or something along those lines just to bolster the soft tissue. But that goes to show you that it's sensitive there. And so a patient who's a cocaine user will cause vasoconstriction of that mucosa that already does not have a periosteal blood supply. And so it's relying on surrounding mucosa that does have a periosteal blood supply. And so cocaine touching this area that is vascularized only by the surrounding that's over top of this implant will cause necrosis of that quite easily. And then the implant gets exposed in the nose, they'll be able to feel it. And then, you know, obviously things that are exposed to either the nose, mouth, or sinus is going to be a dirty thing. So we want to minimize that. All right, now, why Norris? So all of these cases that I've showed that are crazy and sort of more on the difficult side or more on the challenging side, I don't think it would have been possible without having this system because of the cleanliness of the zygomatic implant, the amount of torque that the tough implant and the zygo and the pterygoids can achieve is just phenomenal. Not to mention the multi-unit abutments that go all the way up to 60 degrees is paramount to getting us well-positioned platforms in the prosthesis of the extramaxillary implants. A lot of other systems of zygoma only provide multi-unit abutments up to 30 degrees, which would cause the access holes to be very palatable. just like how they used to be with the intrasinus zygos. And so, in addition to that, it's an internal hex, and so any sort of conversion from another system will be very simple and easy. You don't have to throw away your inventory. And again, every aspect of what I use with this system has been thought through, and I can tell that an engineer has thought this through and has really honed in on what's important and what's not important. So that said, that's all I have for you guys. I want to thank everyone for watching, and I'd like to open up for questions. Thank you.
Hi, welcome to the 2020 Academy of Oral Surgery's Fall Symposium. I'm Dr. Carlos Moran, the host of this program, and today I'd like to introduce our special guest, Dr. Ashimi Balarao. Dr. Ashimi received her bachelor in dental surgery from Nahi Hospital Dental College in Mumbai, India, where she also earned her master. She also received her postgraduate diploma in medical legal systems from the Symbiosis Institutes of Healthcare, Pune, India. Thank you, Dr. Hashimi. Thank you, Dr. Hashimi. It's a great pleasure to have you here today, and the floor is yours.
Hi, friends. This is Dr. Ashwini Balerao speaking from Mumbai, India. I'm an oral and maxillofacial surgeon, passionate about my work, family, and hobbies in that order. Today, let me share surgical pearls for extraction of wisdom teeth. For last 27 years, I have been practicing exclusive oral surgery, and the sense of gratification and happiness that my patients faces after treatment gives me is unparalleled. Every year, I have a simple rule which I follow. Learn something, teach something. Live to learn, learn to teach. So today I shall be sharing only the clinical pearls, making you ready, making you a winner from tomorrow itself. You may not be masters in oral surgery, but this surgery is such, if you follow the protocol, if you understand anatomy, and if you follow logic and common sense, you can master this basic surgery in dental field. So surgical skills are the foundation of every branch. You have to strengthen this foundation because without surgery, you will not be able to master anything else, neither in endo, nor in prostho, nor in perio. Because once you know how to handle the complications which you face when you're doing surgeries, you're able to handle anything and everything. So follow the 5 commandments. What are they? Establish correct diagnosis. Does it require surgery? Don't be a butcher. It takes a better surgeon to say no more times than yes. Plan the procedure to the last detail. Sterilization and instruments is a big part. Follow-up care of the patient, very, very important. Treatment planning. Now, what should be your objectives? Obviously, very short operating time, minimal trauma to the soft tissues, adjacent teeth and bone, and the procedure, even though you're doing it under local anesthesia, has to be painless. And of course, no complications. The first thing what you do is take a proper X-ray. When you look at the X-ray, do you just look at the position of the tooth? No, you look at the angulations because angulations determine the path of removal. Look at whether there is a pathology associated with the tooth. Look whether the tooth is close to any vital structures such as the maxillary sinus or the inferior alveolar nerve. Look at the depth in the bone. Look at the extent of roots, thickness of roots. Taking a OPG is a must. A CBCT should be taken when you feel that the tooth is very close to the nerve or to the sinus or is multi-rooted or has an abnormal pathology attached to it. This was what they used to do 4 generations back. Luckily, we have progressed to much more sophisticated methods. Follow 2 golden rules. Practice makes perfect and never skip steps. And follow the standard protocol, which I will go through one by one. Medical evaluation. It's common for every oral surgery. Diabetes, check blood sugar postprandial and fasting. It has to be maximum 180 or take physician's consent. Cardiac disorder, history of invasive procedure, stop the blood thinner 2 days before, on the day of the surgery, and 2 days after. Any infectious disease, ask for the medication. Especially with COVID, ask whether the patient has been on a steroid therapy. If the patient has already been on any steroid therapy because of any immune disorder, then take the physician's consent or increase the dose of the steroid for 3 days after the surgery to help the body cope with the surgical trauma. Then taper it down to the normal dose. Avoid any drugs the patient is allergic to. The X-rays show you the correct mesiodistal dimension as well as antero-posterior dimension. IOPA should show the distal bone. OPG shows you the shadow of a nerve. CBCT shows you the colored picture, which makes it easy for the patient to understand the possible complications. These were casually taken and we realized there was a cyst involved. So this shows you the importance of taking a OPG. Level of difficulty. Don't think that a straight tooth is a simple one. Mesioangular is the easiest. Vertical, deceptive and difficult. Distoangular, difficult and time consuming. Horizontal, very difficult. Never judge a tooth by the crown, but by its roots. Now, how do you know whether the tooth is surgical or non-surgical? It's only in the case of vertical position. Check the distal bone above the CEJ of the 8. If it is above the CEJ, it is definitely surgical. If it is at the level of CEJ, check whether it's a conical root, a small crown, intact crown, and an intact 7 to be used as a fulcrum. Try elevation. If you're using too much force, that's throwing all your body weight behind that tooth, then it requires surgery. If it's a multi-rooted tooth, if the distal bone is above CEJ or at level of CEJ, carious crown, abscess of 7, don't think about it. It's a no-brainer. Please take a flap and do it the surgical way. If it's a supra-erupted, periodontally compromised tooth, then elevate it out gently. Preoperative medication should be antibiotic, any anti-inflammatory drugs, and stop blood thinners. The surgical plan, you should always follow the reverse order of the procedure. First, decide in which way the tooth is going to come out. Decide what's blocking the tooth from coming out. Decide where are you going to elevate it from, where are you going to remove the bone from. Lastly, design the extent of the flap. Whether it's surgical or non-surgical, the tray should be arranged in the order of the instruments you're going to use. So first is local anesthesia, number 15 blade, periosteal elevator, Langenbach's retractor, straight elevators, extraction forceps, needle holder, suture, suture cutting scissors, a betadine swab to scrub the patient's, mouthwash for the patient to rinse his mouth, gel foam, suction tips. All this should be arranged in a proper orderly way so it becomes easier for the surgeon to just pick the required instruments without wasting time turning 360 degrees or searching for it. These elevators are hero number 1. Depend on the elevators, not on the forceps. You should have an arrowhead tip. You should have a broad tip. You should have a luxator. The elevator tips should be concave and not flat. Invest in elevators, not in forceps. Now, what are luxators? Luxators are actually elevators. The blades exert more force. They are thick-handled and they are used to move the tooth from a locked position. However, they should be used very carefully because they can fracture buccal cortex or tuberosity. Directa luxators are the gold standard for oral surgery. The primary burr for bone cutting is 703 straight fissure. You get it in any company. The material is carbide. To section a tooth, you use a long shank air rotor burr, and they are called as long shank surgical burrs, either Comet or Trihawk or any other company. You can make out the difference in the shanks of the burrs. The upper one, the upper handpiece shows a cavity cutting burr, while the lower handpiece shows the surgical burr. So please use a surgical burr, otherwise you will end up chipping at the crown of the tooth. What do? I personally use Directive Luxators and any Trihawk or Comet carbide surgical burrs with a long shank to section the crown. What is a surgical procedure consist of? Local anesthesia, flap design, drilling, tooth removal, and lastly, suturing. Local anesthesia given is xylocaine or lignocaine 2% with or without adrenaline. These are the drugs used in conscious sedation. They are not used much in India because of legal factors, but they are used very commonly in the Western countries. If you are taking all 4 wisdom teeth out at the same time, I would suggest take the patient in a hospital and use general anesthesia using nasal intubation. The flap design is important. Always take C-shaped flap in the picture C. Trapezoidal flap with a wide base. Wider the vision, better the vision, the surgery becomes easier. And base of the flap should always be wide because the blood supply to the periosteum, to the coronal part of the flap, to the tooth, to the suture line comes from the base of the flap. The bone removal should always be below the CEJ. You can use an air motor or you can use a micromotor with a straight handpiece, and the number of the burr is 703 or 702. Always remove enough bone below the CJ from the buccal aspect, distal aspect, and interdentally between 7 and 8. When it's a distoangular tooth, the extent of bone removal on the distal side is naturally more because the tooth has to move backwards into the ramus and the anterior border of the ramus will block it. So remove more of the distal bone. Straight elevator is the best. Start with the sharp tip, then go to the arrowhead tip, then use a broad tip for more force. Upper third molars always start with the arrowhead narrow tip. For more force, use the blunt tip. Ease the tooth out in the direction in which the crown is facing. For lower third molar, while elevating, always support the mandible in this fashion with your other hand so that you don't dislocate it with your own force. The use of forceps is only for the final 20% and use a cow horn because a cow horn grips the tooth below the furcation. So even if you end up fracturing, you divide the roots and removal of separate roots rather than the root stump is easier. After the tooth is out, smoothen the bony margins and fill the socket with PRF or gel foam. What is PRF? Plasma-rich fibrin, which contains growth factors, leukocytes, and platelets in a fibrin mesh. Fibrin is a bioscaffold. It slowly releases these growth factors. It hastens healing, stimulates hard and soft tissue formation, promotes or increases the blood supply, reduces the post-surgical pain, and there is just no incidence of dry socket. So this is what I do. I have finished the surgery. My PRF clot is ready. Pack the PRF clot, suture. After 7 days, I have this absolute airtight closure and beautiful attached gingiva. So let's look at tissue management and patient care. Every surgeon should remember sutures directly affect the final healing. So please don't give it to your assistant. Take equal bites from the edges. Tissue edges must approximate passively and don't pull the suture to close the flap, undermine the periosteum, and tie 3 knots. How you understand the periosteum with the fluid The suturing materials are catgut vicryl, but we use black braided silk or vicryl. Absorbable, non-absorbable. Absorbable are given only if the patient cannot come back to you for suture removal. Suturing techniques for a third molar surgery, just learn 3. Simple interrupted, figure of 8 or horizontal mattress. The needle holder should be long. The suture cutting scissors should be curved.
Should alternate sutures, one edge,
And
other edge.
always
Don't go into clockwise, anti-clockwise. It doesn't matter. What is important? The knot should not come out. First knot, second knot, third knot. Many of you all try to be stylish, one clockwise, the other anti-clockwise, and you'll end up going in knots.
So it's also important to understand that where do you hold the needle and where do you hold the thread. So the suture needle should be held by the holder 1/3 from the eye and 1/3 from the tip of the holder. That's the ideal position. Sutures given should be approximately just 3 or 4. Start with the topmost suture first, then take the one distal to 7, and the buckle stitch should be the last. You can omit the buckle stitch if required. Sometimes when the 7 is absent, at that time make the ditch in the bone and use that as a fulcrum to lift the tooth out, and then make sure you have edge-to-edge closure. In a horizontal tooth, you can either section the entire tooth vertically downwards or through the CEJ as you see in this picture, or vertically downwards through the CEJ as in this picture. Whatever is easier, it all depends on the mouth opening and your ease with a particular handpiece. For an impacted upper 8, just make a ditch between the 7 and the 8, and since the maxillary bone is D3, D4, just elevation is enough to expand it and for the tooth to slip out. If you have an upper 8 positioned so high up, don't bother to take it out. It's not the cause of TMJ, not the cause of pain, nothing. Please leave it till it migrates coronally. When do you call a surgeon? You are not defeated. You are just wise. So try all these on your own first. For these categories, call a surgeon, assist him, or practice your skills in some charitable hospital and then start operating in your own clinic. Let's see a small video of taking the IV. I always injection dexamethasone and injection diclofenac before the surgery so that the patient is comfortable once the local anesthesia wears off. Use a number 25 scalp vein. Let the blood flow out to make so that you know you're in the blood vessel. and inject the patient while the local anesthesia is acting. Let's see a video of a lower rate. This was an ortho case, so elected extraction. Number 15, blade. Incision given between mesial and distal cusps of 7, sparing the papilla, go along the cervical margins, backwards, around the 8, and along the anterior border of the rims. You get more access if the patient's mouth is actually closed, but for the sake of this video, we had to force the mandible open. Run the blade once more because it has to be a clean incision. Make sure that the blade rests on bone. Now use your periosteal elevator to separate the papilla and separate the flap. It has to be a clean reflection. If you see fibers of the periosteum stuck to the bone, then what you're supposed to do is use the knife to cut the fibers rather than stretch it, because you'll only induce bleeding. A clean table, the buccal cortical plate should be cleanly visible. There is no bleeding there. The fibers distal to the 8 are always tenacious near the raphe, so use a blade to make a clean cut. This is how clean your incision should look. If the patient feels pain at this point, inject between the tooth and the bone. Start the drilling either mesially or distally. Irrigation with a cold saline is must to prevent bone heating. Bone heating causes osteitis and dry socket formation. Bone removal should always be end below the CEJ of the 8. Distally, as far as the lingual cortex, please don't reflect the lingual flap because that contains the terminal branches of lingual artery. You may cause lingual paresthesia. So never ever reflect the lingual flap. This is how wide the gutter should be. The arrowhead elevator, interdentally. Support the patient's mandible at all times. It's blocked at the distobuccal level. More concave the elevator, the more effective it is. I'm using it as a spade through the buccal gutter. and it's out. Look how curved the roots were. So elevate slowly. Use the forceps only when the patient is grade 2 mobile. Always smoothen the edges of the socket with any round shaped or a dumbbell shaped vulcanized burr. Again, here irrigation is a must. Flush it with saline to remove any debris of interdental bone chips, fillings, cement materials, any foreign body that might cause disintegration of the blood clot. Pack it with PRF if you have it, or pack it with gel foam and suture. This was the tiny piece, but it's important to remove this tiny piece of interdental bone and only then close. Otherwise, you might have incidents of secondary bleeding. Now pack it with gel foam and start taking the sutures. Now, what is coronectomy? Coronectomy is simply in places or in situations where the tooth is very close to the nerve and the complications would be far harsher than removal itself. It is wiser to remove the crown only and keep the root inside. So how do you know that there can be inferior alveolar nerve injury? By all these points. So when you have this scenario as seen in a CBCT, offer the option of coronectomy to the patient. The contraindications are non-vital tooth, infected tooth, tooth is mobile, if a patient has undergone radiotherapy, immune disorders, or if the tooth is carious. The operative technique is absolutely simple. Till the gut ring, the crown should be sectioned at right angles to the root stump. The root complex should be tightly wedged inside, and then you make a ditch or you slope the tooth downwards along its margin so that the bone overhangs over the root stump. This enhances new bone growth over the roots. The dental pulp tissue does not require any treatment or any pulpotomy or anything like that. Smoothen the bony gutter, rinse and suture. These are the simple steps. Can you see the gut ring in figure D? Post-operative care is regular care. Every 6 months or 12 months, X-ray needs to be taken and you will see that the root complex does migrate coronally. So our conclusion is that coronectomy is a safe procedure. Rather than have the patient blame us for paresthesia, one must offer this solution or option to the patient and get a written consent from the patient. The post-operative care has to be this: holding the gauze pack for an hour, soft diet for 6 hours, no spitting, no rinsing, mouthwash after second day. Antibiotic, non-steroid anti-inflammatory drugs, antacid, a probiotic, and a mouthwash. I'll skip this because this is very India-based. So what do we know? X-ray reading is critical. Treat cellulitis first. Ludwig's, refer to a hospital. Don't treat it in a dental clinic. Section after you decide how the tooth is going to come out. Don't operate blindly. Take a wider flap. How do you avoid complications? To avoid a broken tooth, elevate thoroughly. Use cowhorn forceps. To prevent intra-op bleeding, take a clean flap. Don't use winter crier elevators. To prevent secondary bleeding, flush the debris out and smoothen the sharp bony edges. To prevent dry socket, irrigation with cool irrigant. Don't overcure it. To prevent paresthesia, maximum 6 cc to 8 cc LA, and don't lacerate the lingual flap. Dislocation of condyle, support the mandible with the other hand. Fracture of angle mandible, always understand that the extent of bone below the roots of the tooth should be double than the length of the tooth. How do you reduce a dislocated condyle? When a patient walks in, first give him a tranquilizer like a diazepam to relax his muscles which have gone into a spasm. Then go backwards, one direction at a time, backwards and upwards, and get his condyles into position. Out of habit, he will slide his mandible forward. You will have to be patient with him and train him to glide his mandible backwards and close normally. Post-operative management of bleeding: if it's a socket bleed, place bone wax. If it's a soft tissue, cautery or mucosal injection of any hemostatic and pressure pack. If it's edema, chymotrypsin, dispersine, or corticosteroids. Hematoma is when you get serous discharge on the next day behind the 7. That's when you release the lowermost suture and hot compress application helps. Ecchymosis happens in fair patients. That's too much of ice application. Thrombophоб gel is the only solution. Trismus is because of pain, so muscle relaxation exercises, muscle relaxants, alternate hot and cold fermentation. Dry socket, it's only vocal anesthesia. That's reassurance that helps it. It's because of less blood supply to the bone socket. Mix zinc oxide with cotton fibers dipped in benzocaine, iodine, and betadine. Pack the socket with this plug. Just push it in, ignore it. After 7 days, as the wound heals from bottoms up, the dressing comes out on its own and you can just pick it out with a probe. Haste makes waste. Patience is a virtue. So follow the steps carefully and you won't go wrong. You can follow me on Twitter. You can follow me on Facebook. I would like to thank my family for standing by me in all tough times and really encouraging me. Can have it all. And that's the next combination. We always have the will to learn and want to help it. That which burr do you use? That's any straight fissure carbide burr. The second question is do you need to prescribe antibiotics for dry socket? No antibiotics, only painkillers and oral hygiene. What do you do in medically compromised cases? Take the physician's consent. How soon can you take a third molar out after COVID? Once the patient gets a negative COVID certificate, wait for 3 weeks. Make sure he has finished double vaccinations and then you can take him in your clinic for surgery, or healing would be compromised and you yourself would not be safe. Fourth complication is, do you use air rotor? I use air rotor selectively only to section the crown, because using air rotor is dangerous as it may cause emphysema. Micromotor is always the number one choice, or using a straight handpiece on a physio dispenser is the number one choice. I've had my share of failures. One cannot be a surgeon without failures. That means you're not operating enough. On that note, I would like to say goodbye and thank you, AAO, for giving me this opportunity.
What's going on, everybody? Hope you just enjoyed that great CE course. I know the AOS is very excited about bringing all this education to you this weekend. And as promised, between these CE courses, we wanted to take some time to highlight some of the great companies in our profession that on a daily basis are creating innovations, creating products and services, all in an effort to help you move forward in your dental practice. And so we want to continue that going. I'm very honored and excited to have Mike Sula with us, who is the sales director at Studio 88. What's going on, Mike?
Hey, John. Thanks so much for having me on today. It's great to be here.
Absolutely. My pleasure. All right. So Studio 88, I'm just going to frame this out for everybody, and then Mike is going to give you guys all the details. I don't know, Mike, maybe the best way, I think about it and say a marketing company that helps and is helping dental practices and dental professionals tell their story. I know you guys probably do so much more, but when I think about the brand and I think about the company as a whole, I know that's what you guys are doing. You're growing like crazy, which is awesome. You're helping dental practices all over the country. So yeah, I wanted to turn over to you and just talk a little bit about what Studio 88 is and the type of work that you guys are doing.
Sounds great. Thanks, John. Yeah, Studio 88, that haven't heard of us, we're dentistry story-driven marketing agency. So our approach is we first get to know a practice's story, what makes them unique, what is kind of true and authentic to them, and then we build that out into the digital space. Because it is true and authentic, we believe it's better marketing at the end of the day. So if you get that basis right up front of telling that accurate story of who you are, of connecting to other human beings to give dentistry, we believe that you're going to end up winning at a higher level at the end of the day.
Yeah, I love that. And as you know so well, Mike, it's one of those situations, all of these dental practices have been hearing for the last 3 to 4 to 5 years, the importance of marketing their practice and SEO and social media. And it's all important, as you know. But before you even get to that finish line, you got to create content, right? You got to, like you mentioned, you got to help them identify their authentic story. And I know that's something that you guys do so well.
Yeah, that's, and it's something that I've seen. I've been in dentistry for about 12 years now. And I had the opportunity to start with a similar, more of a template-based dental website company years ago. And, it kind of helped practices get presence, but I also saw a lot of practices pour a lot of marketing dollars into digital ads or SEO to bring them to kind of like a templated or a stock image based site that doesn't really stick your head above the rest. It's kind of blending in with thousands of other dentists that are out there. I found that if you kind of take a step back, find out who you are, what makes you unique, and then build that out, now any marketing dollars that you're putting into the space ends up converting at a much higher level. So we slow down to kind of speed up is our approach to that, I would say.
Yeah, I love that. And so, I think about when I think about a lot of the work that you all do at Studio 88, I think about when I go in and I type the top 10 most popular viral videos on YouTube. And often, Mike, as you know, they are things that none of us would ever think, right, would go viral. It's they're authentic stories. Sometimes they're funny stories. And I think when you relate that to a dental team, and I know that's what you guys do so well, is that you help dental teams bring that out and then capture that on video and photography and so on and so forth, so that the hopes are is that they do go viral with their patient base, right? So that when they do come up with a game plan on social media, that their patients and the people in their community really see them for who they are versus, just their traditional form of marketing of, we do crowns, we do implants, all that stuff. Mm-hmm. It really kind of, like you said, it helps them kind of raise above everybody else.
Yeah, you're right, John, because at the end of the day, I mean, you can be the best dentist in the world, but if you're not connecting at a human level from a digital space, a lot of patients will never get to experience that with you. So it's so important to first have that piece in there. And we've made some exercises to make it extremely simple to first discover that story, through that's photography, through video. Then secondly, really tell that story on your website through a nice, beautiful website design. And then lastly, share your stories, whether that's social media, whether that's Google Ads. So we have very simple steps in place to really help any office find their identity and really truly bring that entire experience to the next level for them.
Perfect. And I think that's a great segue to talk about the process. You mentioned discovery a little bit. I know after spending time in dental practices and having them learn about a lot of these new services I've experienced over the years, they get excited about it. They go to a show, they see Studio 88, like, okay, I know we have to do this, but it just seems so overwhelming, right? Like, where do we start? We're busy working with patients. Can you talk a little bit about the process that you work with practices on, meaning that discovery, I think, is a great way to start, just to kind of break it down for them so they realize, okay, like, you don't have to do this all in one full swoop.
Yeah, for sure. And it can seem like a daunting task, but we broke this down with hundreds of different offices. That probably the biggest line that I would hear is, oh, well, it's not much that's unique about my practice. There's not much. I'm just a dentist and practice dentistry. But what I love to do is really take that dentist and then discover and have different tools to help bring that out of them. So we have a lot of guides in place. So we have something called a style guide where we really get to learn the style or the essence of what that practice is into. And then we have another tool called a brand creator. That's a very nice document, very good team building exercise to really discover what's unique. We ask a lot of leading questions to kind of get the practice to think about why did you get into dentistry? What makes you unique? What gets you passionate? What gets you, like, kind of fired up for your day? What do you like? What do you dislike? So we really help that to craft the messaging behind the practice. And once you kind of bring through those tools and we ask those leading questions, it really starts getting drawn out of each of the individuals. I think what happens is dentists day to day, you get stuck in this almost a rut of just, okay, I'm coming in, I'm seeing patients, I'm doing this work, I'm doing this procedure. And it can be a little bit monotonous to the point where you've convinced yourself that what you're doing is, at the end of the day, you're helping people. It's humans working with other humans. It's a beautiful, innovative profession. And we just want to help display that at the end of the day.
So when I think about the process that you all go through, it takes me to, I'm on analogies today. I don't know why, but it's kind of like today's like analogy day. And I'm thinking about like HGTV, right? For anybody that watches it, and you watch those home shows and they start with the home is, needs to be renovated or what have you. And they go through that whole process. And then there's always that really cool time at the end of the show, the reveal, where they walk them up the steps and they open the door. They get a chance to see all the work that was done and the emotions that come from that. I would have to think, Mike, that when dental teams, take that step forward, make that commitment to work with a company like Studio 88, and they go through that process that you talked about. They start to share who they are. They start to tell their story. And then you guys do your magic. You create the content, you create the video, and so on and so forth. That on the other side of that, when they watch it for the first time, then they realize the importance of just how cool it is to be able to brand themselves and showcase themselves differently. I would have to imagine that's a pretty cool process.
Yeah, it's a beautiful thing, that end reveal. We love revealing websites through Zoom calls like this because it is such a beautiful thing where we've had a lot of our clients actually be brought to tears from what they see in that finishing product. Because I believe that what everyone wants out there is an identity. And when you can really find the true essence of, wow, that's me, that's exactly me, that's my team, and we're now putting that out into the space, they understand that they're going to be able to connect with a better patient, someone that actually is kind of shares the same values and shares what's important to them, same as the practice. And they're going to get treated like a human being, like everyone wants to be treated, with care. And, obviously bringing in the uniqueness of the practice and whatever services that is, but it all starts from that human connection.
Yeah, it's pretty awesome. All right. So for those that are watching, you will look below. We went ahead and put the link for Studio 88 so you can get in touch with them, learn more about all the services they provide. One of the last things I wanted to ask, Mike, is that, for any practice that's out there watching that wants to learn more about you guys and certainly take advantage of some of the services, what is typically the first thing that you do? I mean, I know you mentioned discovery, but could you just kind of walk everybody through how that exactly works as far as, getting things started?
Yeah, absolutely. I would say the first step, we do a complimentary strategy call for anyone that's essentially looking to work with us. So we'll jump on the phone for 45 minutes, very similar to this conversation. We'll look into what marketing efforts are in place right now. and kind of give a very straight answer of, hey, these are some things you're doing great. Here's some areas of improvement. And if we want to carry that conversation on from there, we can talk about how we can work together, or if it makes sense for us to work together in the future or not at all, we're totally fine with that too. So it all starts with that beginning call that we can take a look at everything they're doing and give some feedback.
Yeah, that's awesome. And I would encourage all of you watching, right? I mean, even if you're at a stage, I think what's great about the work that Studio 88 does is I think if you're at a stage where maybe you have a website already, maybe you're happy with what you have, I think what you're going to discover through this discovery process is that maybe there's more video that you would want to do to add to your website, more photography, or, you know, like you mentioned, Mike, even marketing your practice through SEO and so on and so forth. So I think regardless of what stage you're at in your practice, taking the time to spend some time with the Studio 88 team, I think is always beneficial. Anything that's complimentary is good. And as I have learned through this whole process, right, we always learn more about ourselves and our business when we take the time to do that. So super beneficial. Mike, I just want to thank you. Thanks for coming on. Thanks for the great work that you're doing in an effort to be able to make dental practices look amazing, right? And helping them bring out their stories. And again, I want to encourage everybody to go check them out. Any last words as we wrap for our audience today?
Man, it's been great being on with you here, John. I really appreciate it. And, you know, it's at the end of the day, we really want to help elevate the entire profession. You know, dentistry is a beautiful profession. It's innovative. It's human serving humans. And we want to showcase that. It just can't be done through stock photos. It can't be done through templates. It's got to be your story. And we want to help display that. So I really appreciate you having us on today and look forward to going on in the future.
You got it. My pleasure, Mike. And good luck as you guys continue to do great work. And thanks for watching, everybody. Enjoy the next course.